Good morning, everybody. A nice start of the spring, I think, in Minneapolis. We welcome it with open arms. First of all, welcome to the Grand Rounds and thank you to the exhibitors today, which is Bristol Myers Squibb and AstraZeneca, for supporting this. It gives me a great pleasure to introduce Dr. Fukui, who originally comes from Kobe, which is in Hyogo Prefecture in Japan.
Yes.
I think I'm right. So she finished her medical degree and cardiology degree there and is a practicing cardiologist in Japan. In 2017, she decided to join Dr. Cavalcante in Pittsburgh as a researcher, focusing on CT and MRI. Mainly, her interest was, of course, cardiac MRI and CT. In 2018, she moved here when Dr. Cavalcante also moved here, and since then, she has established herself as a senior researcher and now is an associate director of Cardiovascular Imaging Research Center and Core Lab. She has worked with me for last 2 years, specifically on one of the most complicated subjects, I think, which is TAVR failures. As you know, that TAVRs become very common, and as we know, all biological valves degenerate. These valves are going to come back, and there's a large dilemma on how to treat it. So we have worked a lot together with the whole team in MHIF to simplify this complex problem. She also has more than 100 peer-reviewed journal articles as well as some book chapters, and is an invited faculty now nationally as well as internationally on her subject. So it gives me a great pleasure to introduce her to give us a brief overview of Redo-TAV failure and how do we plan and select patients. Thank you.
Thank you for the kind introduction, Dr. Barbara. It's an honor to present on this topic here today. As introduced, Dr. Cavalcante gave me fundamental training in cardiac CT and MRI and has guided my research work since I moved to the US. Furthermore, over the last few years, I've had amazing opportunity to work with Dr. Barbara, especially for this topic. Since this field has become my specialty, today I'd like to talk about Redo-TAV therapy, its rationale, feasibility, and optimization. First, do you know what the Redo-TAV therapy is? That all current TAV devices are bioprosthetic valves, which means all valves eventually degenerate. When it's degenerated and the patient gets symptom, reintervention would be needed. With TAV, implanting a new TAV device into an old device is one of the treatment options in such cases. Why is this topic important for us to discuss now? To answer that question, let's start with the history of TAV. More than 2 decades ago, TAV was first performed in human, and then it was approved in prohibit or high surgical risk in 2011 in the US, and for intermediate risk in 2016. At that era, we didn't need to care much about TAV durability because many of the patients couldn't outlive the durability. However, since TAV has been approved in low-risk patients in 2019, the situation has changed. As this extensive data from the US showed, nearly half of patients under 65 years old, in which many of them are considered as low risk, received TAV, although a current guideline does not recommend TAV as class 1 or 2 indication for this age group. Furthermore, among patients between 65 to 80 years old, nearly 90% of them underwent TAV. These patients may live longer than 10 years, but current TAV have durability more than 10 years. While a dedicated data on low risk or younger patients is still lacking. Data from the Notion trial and the Balloon-TAV registry, which included patients across all risk profiles, indicated that structural valve deterioration becomes more common after 5 years. In 10 years post-implantation, about 1 in 4 to 5 patients experience TAV dysfunction. Since TAV has been approved in low-risk patients about 5 years ago, we are beginning to see these patients coming back to us. For such patients, we currently have 2 treatment options: surgical TAV explant or transcatheter Redo-TAV. Which should be chosen? To think about it, let's take a look at the outcome data first of each therapy. First, surgical treatment. Several studies reported a high in-hospital and 30-day mortality around 15%. This high mortality rate likely reflects the experience of this new procedure and the urgency of many cases due to high risk endocarditis. However, with the expansion of education and experience, many surgeons now feel this mortality rate is decreasing. We are now waiting for updated data. How about Redo-TAV? Data from the Redo-TAV registry run by Dr. Landes, as well as the TBT registry, show that when Redo-TAV is feasible, the 30-day mortality was less than 5%. Furthermore, data from Center for Medicare and Medicaid Services between 2012 and 2017 show that Redo-TAV had lower 30-day mortality and base, but similar 1-year mortality compared to surgical treatment. While still we don't have long-term data of these treatments, the choice of Redo-TAV seems to be reasonable. So which would you choose if you are a patient? Now let's imagine that you are 73 years old and as diagnosed as severe aortic stenosis. You are in the low risk, and for the index first procedure, which would you choose? Surgical aortic valve replacement or TAV? Who would you choose surgical TAV? Who would you choose TAV? Okay, and people who chose TAV, so 10 years later, now you are 83 years old, and you're still doing okay, enjoy gardening, time with grandkids, but you got symptoms due to TAV dysfunction, and you are now intermediate risk. So which would you choose? Surgical open heart surgery or transcatheter Redo-TAV? Who would you choose? Surgical. Who would you choose? Redo-TAV. Okay. So reflecting such people's preference and of course surgical risk, the number of Redo-TAV is increasing. This trend is clearly illustrated by data from the TBT registry up to 2023. Furthermore, a simulation study by Dr. Genero predicted that within the next 10 years, the number of patients who need Redo-TAV could increase 15 times larger than the current level. The wave of Redo-TAV is coming. So people may say it's tsunami, which is Japanese word, but real tsunami is devastating and unpredictable disaster who claim countless lives. So personally, I prefer not to use that term in the medical field. And also, this wave of Redo-TAV is predictable. So why not just prepare for it? You may wonder that TAV is now established therapy with mature technology and experience. Additionally, valve-in-valve, TAV-in-TAV is also routinely performed in our clinical practice. Then TAV-in-TAV shouldn't be different or difficult. But is that really the case? So here are from early experience. In one case, a Sapiens lead was successfully implanted within the generated evolute. However, in another case, although the Sapiens lead was implanted at similar position with the first case, the patient crashed immediately after the deployment. Why did this happen? Clearly, we must avoid that, but how? At the beginning, we saw TAV-in-TAV should be similar with TAV-in-TAV, but the truth is quite different. In surgical valves, the dimensions are maintained even after surgery, and they are constantly sutured at annulus level. This leads to consistent sizing and positioning for TAV implantation. Furthermore, surgical valves tend to have similar stent height and relatively lower profile, which makes the coronary risk assessment less complicated. On the other hand, transcatheter heart valve have a different 3D shape and expansion after in vivo implantation. The depth of index TAV within the native anatomy varies depending on the case, and each TAV has different unique structure and leaflet height. As such, TAV-in-TAV is not as simple as TAV-in-TAV. For safe and optimal Redo-TAV, first we need to understand the relationship between the native anatomy and the index TAV, and then relation with the second TAV. So the triangle relationship is always complicated. Now we understand that the wave of Redo-TAV is coming, so we have to prepare for it. But it seems TAV-in-TAV is not as simple as TAV-in-TAV. So how can we appropriately assess the feasibility of this therapy and perform it to our patients safely? That was our first question when we started working on this field. There are several bench testing introducing new and unique phenomenon specific for this Redo-TAV, like a leaflet overhang and sinus sequestration. Dr. Okada, former scholar, and Dr. Babat and I were trying to solve them out, but they were so confusing and unorganized. So we understand each individual phenomenon, but there were no smooth connection between them. So we are kind of at the end just discussing how chaotic situation, blah, blah, blah. At that time, Dr. Babat clearly told us that I know the problem, so no need to explain to me. Just let's focus on finding out solutions. So throughout weeks and months of internal discussion, along with the external collaboration with key opinion leader in this field and the R&D team of each industry, we eventually identified 4 key constellations to assess the feasibility of this therapy. And sequence order of the assessment is also critical. The first consideration is second TAV compatibility. Which second TAV type can be implanted in a given index TAV, and optimal implant position for secure anchoring and appropriate function of the second TAV. Second TAV sizing. This is also for secure anchoring and appropriate function of the second TAV, and coronary risk assessment. We must avoid the coronary obstruction on table and ideally maintain coronary future access. So next, let's dive into each constellation. So first of all, we need to understand each TAV structure. So for Sapien 3 family, leaflets start at a few millimeters above the inflow and extend to the top of the commissure TAV, which means after second TAV implantation, the leaflet completely pinned out. The top level of the leaflet will be top of the commissure TAV. For Evolute, we use node for landmarks. And the skirt cover up to node 3, and leaflets start at node 3 and end up to node 5 for side 23, or node 6 for the other sizes. For accurate, leaflets start at the bottom of upper gland, and so on. So each TAV have a different structure, unique structure with different landmarks. For the compatibility between the index and the second TAV, we can simply classify the four combinations: short in short, tall in short, tall in tall, and short in tall. Technically, at this point, only SAPIEN is approved by FDA. But in real clinical world, tall valves like Evolut are also used as a compassionate use. Based on bench testing and early experience, the optimal implant position for short in short is outflow to outflow, tall in short, inflow to inflow. After second TAV implantation, a tube graft is created by pinned leaflet of index TAV, which is referred as neo-skirt. For CT planning, we propose defining the top level of the neo-skirt as neo-skirt plane, NSP, blue line on this figure. And for short in short and tall in short combination, this blue line is generally single level, one level, unless the second short valve, for example, the SAPIEN is implanted lower. For tall in short, this blue line was never lower, even Evolut is implanted lower, but only could higher when it's implanted significantly higher. For tall in tall, won't change, always commercial TAV level. For short in tall combination, this is very unique combination because this blue line can be adjusted by adjusting the implant position. But remember that the leaflet of Evolut starts at node 3, so to treat degenerated leaflet, we need to implant at least node 4, but no need to higher than node 6, where the commercial TAV level. As you can imagine, when a SAPIEN 3 is implanted lower level, the leaflet of Evolut could overlap to the SAPIEN 3, which is referred as leaflet overhang, and you can see on this video. A bench testing was conducted to evaluate the impact of this phenomenon on hemodynamics and demonstrating acceptable line hemodynamics in terms of mean gradient and regression fraction. Nowadays, this acceptable hemodynamics also confirmed in real clinical cases. However, we still don't know the long-term impact of this phenomenon on valve durability or the patient outcome. So ideal implant position for this combination is node 6. But this high implant position could carry high risk to coronary in many patients. We cannot compromise coronary flow on table. So in such cases, lower implant position could be an alternative. Next, sizing. So currently, there are 3 options: in vivo CT sizing, in vitro bench sizing, or use pre-index native annulus. Based on post-Redo-TAV CT, we currently recommend in vivo CT sizing because under or uneven expansion of index TAV is common, which could impact on the second TAV expansion. And especially for short and tall combination, second TAV size may change by index TAV size and implant position. Each industry has their own in vivo sizing strategy. For index SAPIEN, use average area at 3 levels. And for Evolut, use the average area at neo-skirt plane you choose and 3 nodes below. Last but not least, coronary risk assessment. It's important to consider not only direct coronary obstruction caused by the neo-skirt directly obstructed the coronary ostium, but also the situation known as sinus sequestration, where the neo-skirt completely sealed off the Valsalva, sinus of Valsalva. To assess both risks, first, we need to identify the coronary risk plane, which is determined as below the lowest coronary ostia in relation to the landmarks of the index TAV. For index sapien, below or above the top of the commission TAV, for index evolute, node. Each patient has different coronary risk plan based on native coronary height and implant depth of the index TAV, and assess the relationship with the neoscat plane, blue line. So when the coronary risk plane is above the blue line, risk to coronary is considered as low. But when it's below, which means either or both coronary will face to tube graft after second TAV implantation, so we need further assessment. How? When the blue line is below the ST junction, most likely the level at the outflow of the second TAV is the narrowest. So we need to measure this level as a valve to aortic sinus. When blue line is above the ST junction, in most of the cases, the level at the ST junction is the narrowest. So we need to assess VT-SGJ as well. So once you identify which level should be assessed, move to the cross-sectional view and measure the distance to the aorta. When we choose valve expandable valve as a second TAV, this valve could expand the index TAV further, which means decrease the distance, increase the coronary risk. So we need to take account of it by drawing a virtual circle of second TAV size chosen and measure the distance from the virtual circle. And identify the narrowest valve to aorta distance among VT-SGJ, valve to aortic sinus, or valve to coronary, and apply for this risk classification. This cutoff value of 4 and 2 millimeter are based on TAV-in-TAV experience because we don't have enough data on TAV-in-TAV. So probably we will need to refine this cutoff value in near future. So based on these considerations, we develop a step-by-step algorithm for pre-procedure CT planning and publish them in this review article. In this article, first we standardize terminology and provide the detailed information of each TAV, along with a comprehensive explanation of step-by-step algorithm. Alongside this, we launched the Redo-TAV app last year as a practical tool for everyday practice, ensuring consistency of measurement and enhancing patient outcome. We've also published several papers assessing the feasibility of Redo-TAV following sapiensly, evolute, and accurate implantation. Overall, Redo-TAV is expected to be feasible in 60 to 80% of patients. This app is a result of extensive collaboration under the support of Lecture Hacker family. And I'm also expressed that I'm amazed by super organized skill set of Madi. And I also like to expand my gratitude to the Quora member for their understanding and support, as well as my beautiful daughter who gave me this stress relief gummy. Yeah, I was so intense at that time. So let me connect my cell phone to the monitor to show you how exactly the app looks like. So now you can see my cell phone, right? And here is the all app Dr. Babat has developed so far, and the Redo-TAV is the host one. Here is the home screen. When you already know your case is feasible or Redo-TAV with a certain second TAV type and size, in that case, you can just go directly procedure guide and select the index TAV type and size, for example, evolute. And second TAV is sapien, site 23, based on CT assessment. And you get the optimal implant position for this combination. So when you choose node 3, you will get a deployment video guide and also this figure, how it looks like after implantation. So this is very specific for valve type and size. So if you change to the node 4, you get that specific figure as well. And when you would like to do CT analysis by yourself, go to CT planning. So here is all steps. It looks like a lot, but once you follow it, you won't miss any critical assessment. So just let me quickly go through using the example of index SAPIEN, slide 26. So first, you get the fundamental information of this app. And then select the failure mechanism, commercial alignment. All information you select or enter will be gathered for summary report at the end. So as step 1, measure the area at these 3 levels for this pulse. So I quickly enter the value. I just make up some like number. You can also enter the perimeter. Oh, that's anyway. And then step 2 is identify the coronary risk plane. So for example, the bottom of RCA is above the stent frame, but LCA is below. So app automatically identify the coronary risk plane. And then move to the step 3, select second tab. So technically, we can use any valve for index SAPIEN, but I would just choose SAPIEN 3. So, and get the information for this combination specific. And again, for this combination, the neoscat plane is single. So just select this level. And then for this case, the coronary risk plane is below, automatically identify that. So we need further assessment, but after second tab sizing. So we already, next step is the sizing. We already enter the area at step 1. So at that point, we just make sure the number are correct. And then you will get the average area, calculated average area. And based on that in vivo UCT sizing and IFU table of the second tab, you choose the second tab size. For this case, I will choose size 23, which is one size smaller than in vitro sizing. And then do some like educational slide and do next step is a coronary risk assessment. This page is kind of my favorite. So because based on what you enter and selected so far, NSP and then the bottom of RCA and LCA, app automatically identify the relationship. Now, for this case, RCA, neoscat plane is below, which means no risk to coronary, so no need to further assessment. The automatically gray out. But for left side, we need further assessment. So we need to do that left side assessment. If it's below the SG junction, we don't need to assess a VT-SGJ, so we need to enter VTA where it's like. And then automatically identify the null-rest value with the color coding, like a risk classification. And next step, and then you will get the summary report. With this animation, visual summary, demonstrating the relationship with the neoscat plane and each coronary and SG junction. This visual summary report is important because there are always days and weeks gap between the analysis and the planning. So once take a screenshot and then bring to the CATE lab. And you may also wonder if it happens if we change the second tab type. That case, change the second tab and bring back to you the step 3, and you can do the same analysis for other combination. And then compare the result, and then operator can choose which one would be better. The app also further access function like a procedure data outcome. So this you can use for your record for registration. Once you, after on the cut level, you enter the index tab size and second tab size, and then put the procedure outcome. Did you do the pre-dilatation or how much volume you use? You can use that one as well. And blank summary report. So when you ask the industry to do the pre-CT analysis, you will get a summary report without a visual such animation. In that case, you enter the all information here, and then you can get the visual summary report. And also, thanks to the amazing collaborator across the world, we have several educational contents about coronary access of the procedure. So here, there are several video contents on YouTube. And also, these are actually not limited to Redo-TAV, but have contents about surgical TAV explant. So thanks to the collaboration with the surgeon, we can have some like a surgical video about the tips and tricks for surgical TAV explant, like this. Sorry, how can I go back? And then last but not least, we also have the one seat city planning chart. So like maybe if you think that's all step is a little bit too much, you can get just one seat chart for all step-by-step algorithm. You can download it and print it out and keep aside when you do the analysis. So this is a quick overview of the app. So please download it and explore them. So now let me stop sharing and then come back to the last part of the presentation, which is optimization. So how can we achieve better outcomes for patients? Let's explore this concept using a case example, which is a degenerated avulsion. I'm going to go quickly show the step-by-step procedure analysis. Step one is assessment of the index tab, including area measurement, identify coronary risk plane, which is node 4 for this case, and select SAPIEN3 as a second tab. For this combination, node 6, 5, or 4 is the acceptable possible implant position. And do the assessment between the nail scat plane, coronary risk plane, sizing, coronary risk assessment, and eventually you will get the summary report for each possible implant position. So for this case, node 6 implantation is considered as intermediate risk, but low risk with node 5 over 4 implantation. Our operator chose node 5 implantation, given the balance between the coronary risk and the degree of leaflet overhang, and SAPIEN3 was successfully implanted as planned. There was no transversal or parabola leakage. Mean gradient decreased to 8 mm Hg. Everyone thought, yes, this is successful implantation. However, unfortunately, patient experienced minor stroke just next day after procedure. The increased pressure gradient was observed on echo, and valve thrombosis was confirmed on CT. Although this is not a common complicate of this procedure, but why did this happen? From our previous study on TAV in native AS and valve in valve, we now learned that TAV deformation, significant under expansion and eccentricity could increase the risk of halt or thrombosis formation. These findings are also supported by several bench testing, showing the relationship between the under expansion and flow stagnation, pinwheeling, reflex stress. So we assessed the expansion of the second TAV expansion on CT, and it turned out only reached to 80%. So how could the procedure be optimized? So based on the bench testing, using the pre or post dilatation could be option. So as you can see here, compared to without pre or post dilatation, this dilatation could increase the improve the expansion and reduce the pinwheeling. This optimizes this phenomenon not limited to short and tall device, but what we observed so far across all combination is, so for example, here, short and short combination. Second TAV the size was chosen based on in vitro sizing, which is same size with the index TAV, and implanted with underfilling. And then only the narrowest portion of the second TAV only reached the 50% expansion. For tall and short combination, if it's implanted too deeper, the expansion of second TAV is significantly constricted by the index TAV. But if implanted optimal position, expansion better, but still under-expanded. So without the post-dilatation. So what we've learned so far is in vivo CT sizing compared to in vitro bench sizing, and the optimal implant position and use pre or post-dilatation are crucial to optimize second TAV function and expansion. So to better understand this procedure, currently 4 prospective studies are ongoing. First, Redo-TAV study in Europe, which has just completed the enrollment. They retrospectively applied the app algorithm. Revolve in Europe, Restore in the US, just included the first patient. They are also using the app algorithm. Refine study, which Dr. Barbat and I are setting up right now, including across all continents, mainly focus on the pre and post CT assessment compared to the other one, main focus was the long-term outcome. So we have done several dedicated sections of Redo-TAV along with the app in TBT, TCT, and PCR London valve, Tokyo valves, and done the first workshop in Brazil, and second one at New York valve last year. And now we are planning to do the first virtual Redo-TAV workshop under the support of MHIF. Not limited to the collaboration with the industry of the industry, but also we are now working with Miho to develop a dedicated software module, which is coming out soon as well. So the key takeaway of my presentation today is first, the number of Redo-TAV is increasing, so we need to prepare for it. The feasibility should be assessed systematically, step by step on pre-CT with the app and for consideration, and let's consider strategizing the optimization of the procedure for better patient outcome. And lastly, my personal key takeaway is this words. So rather than discussing a problem, let's focus on find out a solution. So this has become my philosophy since then. Thank you for your attention. Thank you.
Thank you, Miho. I think most people here don't want to have a tower. I can tell you that much. And I think this was a brilliant overview of this really evolving topic, I would say. So any questions?
Thank you for the great talk. My question is, when we're looking at base TAV valves that have increased coronary access, such as the Evolut FX Plus, how do we anticipate the coronary risk will be impacted with Redo-TAV and TAV on those?
Thank you for your question. Yes, Evaluate is a kind of complicated index TAV. So now, and also FX plus has a slightly different phenomenon. So we now also, so again, first step is understand the structure of each valve. So we now understand that this window start at node 3 to node 4, 5, right? 5, 6, 5. So yes, compared to the previous generation before the FX plus, FX has a better coronary access and also feasibility of Redo-TAV after implantation. So maybe that's yeah. Some more you want more. You need more detail or.
So I think the question is the most important question you asked is people who don't know. So Evolutar, if I just take your cup, so essentially this is the whole frame. It has got very small cells, which are essentially, I would say, 8 millimeters in height or less than that. So now they have cut a bigger window so that you can access the coronary. So that is, but more important is commissure alignment. So to take advantage of it, first you need to do commissure alignment, and then only it is useful. And we are going to see the impact of it in terms of maybe it will reduce the coronary obstruction risk. We are not yet sure will it reduce the or coronary access risk, which is also there. So I think that's why the registries are important, where we see predicted versus observed, and then it will define the problem.
Question is for those young people like me, all of us young people who are anticipating their first TAVR. We're going to be able to say, I anticipate, which will be obviously the best initial TAVR to have, because we almost always have a choice between types. And we aren't quite there yet, but because the denominator, or the number of patients who are getting TAVR at a 50, 55, 60-year-old time frame is still relatively small. But is it possible for me to tell my reluctant patient who says, I'm never going to have surgery, I want a TAVR, I know I'm only 55, well, is it possible for us to tell that patient which is the best index TAVR to get now?
So yes, this is a one important topic we always discuss. So easy. So I wouldn't say easy. So some people easily say, oh, short valve, of course. But the first thing, the most important thing, the successful or the long-term durability of the index TAV is important. So for example, for small annulus patient, in that case, in the current base, so the current data, the supra-annular design will be better for such patient. That case is first focus on the optimization of the index TAV for the patient, and then get the better durability of the index TAV. But at that time, we also can think about how we can secure the feasibility of Redo-TAV by adjusting the implant depth first. So what we observed so far, the high implant position, regardless of any valve type, is always, even the short valve, if implanted higher, that's high risk, not feasible for Redo-TAV future. So not only the valve type, but also how to optimize the expansion of the index TAV for better durability, and also implant position to secure the future feasibility of Redo-TAV. That's. Do you have any other comments?
I think this is a great question because on the surgical side, that is what exactly has happened now. So surgical valve designs, which we have been working on for a few years, so the external wrap design is kind of disappearing because valve in valve, there's a higher risk of coronary obstruction with that. And the second is, expandable valves have come now in surgery. So the valves we implant now, we can expand them to increase their true internal diameter. So I believe very strongly like FX plus is one of the answers. I think TAVR designs have to change as well. You're absolutely right, because we are implanting them higher. So essentially, we are blocking the next optimal procedure. So that thought process is slowly kind of making its way in terms of how to now change the tower designs. Can we put maybe good markers on the tower? Can we make it a better expansion? I don't know. Maybe we still don't know the answer. But younger patients, this is definitely a worry. I would say that tower explant is going to be probably important in these patients, whether they like it or not. Because in many patients, we are doing now TAVR explants maybe once or maybe twice a month. I think this is going to increase slowly with time.
I would just say congratulations to both of you for taking this topic and really making sense of it. It's incredibly complicated, and congratulations on the amazing work. Can you expand on the concept of the commissure alignment in the index case and how that impacts the redo and what we should be looking at? You mentioned it briefly, but it's part of the app, I believe, but didn't quite catch the specific there.
Thank you for that question. So, yes, so when the, let me go. So, when the coronary risk plan above the neoscot plan, no need further assessment, regardless of the commissure alignment or coronary alignment, should be fine. But when the coronary risk plan is below, and then coronary at risk, and then if there is enough space greater than 4 millimeter, also doesn't matter the commissure alignment. But if it's intermediate risk or low risk, but still your patient only have the option with the transcatheter, I mean, in that case, we need to consider about the leaflet modification, like a basilica or such stuff. In that case, to get the advantage or effect of the leaflet modification, leaflet need to appropriately face to the each like a coronary. So if commissure misaligned, even leaflet cut it out, in front of the coronary is a commissure tab, not the open leaflet. So in such situation, commissure alignment is an important aspect.
So I think that is the reason we are very lucky here, because we get some amazing CT scans, so we can define all this. But there's another procedure called Unicorn, which is being developed. It was first done in Hong Kong, and they've done now 20 cases. So essentially, if you're commissurally aligned properly, your coronary is right in the middle. They perforate the leaflet and displace it completely on one side. So that's only possible if you are up to maybe 30-degree misaligned. And that's the reason I think knowing that beforehand is quite important.
On the initial TAVR and making sure that that's...
Yes. So now the new TAVR technologies allow commissure alignment. So commissure alignment was a concept which I published 8 years ago, I think now, essentially to see how the TAVRs are aligned in the native, because surgically we always align the commissures. And so now that there's a lot of work done on coronary flow, blood flow, etc., all the more TAVR designs allow you to rotate the delivery system in one way or the other and commissurally align. So that's going to be very important, I think, in future. Any other questions?
Thank you very much. Thank you very much. This is an excellent presentation, Miho. So my question is, do you have any insights for Redo-TAV procedures, like in order to get rid of the conduction system abnormalities? Do you have any insights or do you have any suggestions to get rid of these type of problems with Redo-TAVs?
That's a good question. So, yes, that's a kind of a different point from the TAV-in-TAV. So for TAV-in-TAV, always, unless do the fracture, surgical frame restricted to TAV. But for Redo-TAV, if we implant it lower, it could expand further and then damage the conduction system. So could happen. But at this moment, I don't think clear data about the incidence of the use need for the new pacemaker lead after Redo-TAV, but these upcoming study will show us such data.
That's a great point because if the initial TAVR is deep and didn't have a pacemaker, but now you're expanding it further, can it increase it? And the other thing is, many times we can't precisely control the depth of implant as well. And that's why we do multiple level analysis for that reason. But again, this is something in prospective studies will be answered as well. But that's a really good question. There's one more question.
Yo, thank you for this excellent talk. Thank you. So I have a question about the risk of coronary obstructions in TAV-in-TAV. If somebody has a surgical valve, how do we assess? Do you still have the concept of this neoscope plane, or how do you know the height of the index surgical valve in the CT assessment?
Yes, that's also an important point. So in majority of case, so as I mentioned, surgical valve generally relatively low profile, and then only a few case, only a small case reach to that top of the stent frame is reached to the ST junction. So in majority of case, we just care about the valve to coronary distance, right? But this concept, of course, can apply for the TAV-in-TAV. So we always need to think about where is the top level of the tube graft after implantation, even TAV-in-TAV, which is most likely the top level of the stent post of surgical valve. Actually, they are slightly different depending on the different type, but generally top of the stent frame. So the tube graft come to this level. So on CT assessment for TAV-in-TAV, we also need to apply this concept and then need to make sure this top level neoscot plane not reach to be the STJ. If beyond above the STJ, we definitely need to this distance as well.
Thank you.
I think you made a very important point is for last 10 years, we have been measuring VTC as one of the guides. And if it's less than 4, we get worried, and more than 4, we feel a bit relaxed. Here, as you can see, we may have to do more measurements and take the smallest measurement because many times the VTC is very generous, but because the blue line can change, and this has been the hardest concept, I would say, to develop in terms of education because it's everything is very imaginary when you are analyzing it because you are analyzing it on the CT software, but then you have to take these so many permutation combinations in, and that's why we developed the app, and we're going to make it easier in future so that it's easy to understand all these plays of two imaginary planes, I would say, and how you apply it. And Three-Mensio, I think, has done a good job. And do we know the expected date of that plugin?
I believe it's coming May or April, but not sure what's the real date.
I mean, that specific software is going to make life easier because it's going to give people hints on what the next step is and otherwise. So I see there are two of my surgical colleagues here. So Sarah, I just wanted to ask you is like how easy is TAVR explant, and what are we doing here in terms of making it probably that 13% mortality to get it down to maybe 1% mortality.
So, I know if you look at the data, in the last 5 to 10 years, TAVR explant has become a lot more common, and the mortality is higher than a lot of complex operations, even like dissection or complex redos. And so I think the surgical community educating each other on, the nuances of explanting the TAVR, and, it's not something that in training we saw a lot of because we weren't doing a lot of this, a decade ago. And so I think learning the aspects of safe removal and not rushing through it and not damaging the root, and understanding the depth of the implant and how that would affect, um, possibly the mitral interaction or needing to replace the ascending. But a lot of the pitfalls can be avoided with the pre-op CT, I think, and understanding, the age of the implant and also the depth of it. I think the mortality can be much lower than it is currently. It's a learning curve in the surgical community, I think. But, in my experience, it doesn't, short valves, tall valves, I mean, they both can be easy, they both can be hard. If it's a newer valve or older valve, they both can be easy, they both can be hard. So it's a little bit unpredictable, but I think we're getting a better sense of it.
Sebastian, any additions in terms of do you think CT scan? So we are very lucky, Dr. Nickelbein is sitting here. We are very lucky to get good CT scans here. So CT planning, like we do for even first valves. There was a question asked about which type of TAVR device. Can we also say, should these patients have surgery first or then TAVR maybe? What is your feeling in terms of that?
Before that, I want to add something that Sarah said. This mortality for surgery seems very high, but this is also the beginning of the experienced surgical community. And it's also probably older patients that got TAVR. So this younger they are, the mortality should be less. And also the patients that eventually went to explant, they're considered patients that were either endocarditis or some very sick patients. So the mortality does definitely have an effect there, that if you look at nowadays, it should be lower, and probably our own experience is lower too. In regards to surgical planning, I think all our patients that go for standard AVR, we have a TAVR CT to have a very good knowledge before going in there. And that very good knowledge, it's associated to other pathology, ascending aorta, calcification, and also how we can predict what kind of valve implant in there. And I think also the success of surgery should hopefully get the biggest valve possible to prevent any mismatch afterwards.
Thank you. Any questions online? No.
Recommend which valve and which valve. That you go back to your original app.
Yeah, I think you're right. So the original valve-in-valve app, which I developed, was from Common Sense, and in the UK we got regulatory permission because there was nothing available that time, and now FDA and other bodies are asking for more evidence. And although we know the problem here, to be very honest, they want to see prospective evidence, they want to see IFU labels, which is going to take a long time. And hence, although I know what I can recommend, I can't recommend. So we give you a choice, because the problem is, I think till that time, till we evolve this evidence, unfortunately, the only way to propagate proper science is through all these workshops and repetitive talks. That's the nature of the game at present, which is unfortunate. So that's why we give you a drop-down menu to choose the size. And a lot of that sizing is probably Miho. I think virtual circle works well. So we are going to see more. I think in 1 year, this will probably evolve. We have a meeting with FDA soon, and we will get at least some understanding of where we can go from here. Great. So Miho, thank you very much for great grand rounds and subject. Have a good week, everyone.